Good afternoon. Namaskar to all of you. It's our pleasure to be there in this particular session, which is Master Talks on a Cataract Session 1. We all understand cataract surgery is actually the surgery as far as improving the quality of life of somebody. That means we can give a vision which has a quality to improve everything, including the vision, including the lifestyle of person also. And we all know there are various kinds of surgeries in cataract also, and they have been giving absolutely beautiful results to all of our patients. It may be initially ICC, it may be extracapsular surgery, or it may be phaco, or it may be assisted with the lasers, or it may be manual SICS. All these surgery has given the results, not only today, been there for decades and decades. Today we're going to take you through all these surgeries, practical tips, so that we improvise our knowledge on these surgical aspects of cataract surgery. And we have galaxy of speakers here, which includes not only the East Zone, includes the national faculty also. Along with me, I have various other chairpersons, Dr. Raj Shekhar from Bangalore, Dr. Anaga from Mumbai, Maharashtra, and Dr. Amay Kulkarni, koi aur nahi hai. So we four are there. So you can see here we are representing the country itself. And this is AIOS, which is the national organization of our body. And this is the first kind of a such meeting, which is midterm meeting. I think in the past there has been one such meeting, which was I think 2-3 decades earlier. The concept was there. I think that time it would have been much more fruitful to have that midterm. But now the state societies have become bigger than various other national organizations also. You name any state, their national annual conferences are as big as any international conferences. They get a large number of national faculty, international faculty also, and good teaching. And to see the scientific program here also, it looks very, very good. So with this introduction, I would like to give it to Anaga to call the next first speaker.
Yeah, I'd like to call upon the first speaker, Dr. Sabyasachi Patnaik, for tips on topical SICS.
Very wide.
So good afternoon, everybody, respected chairpersons and dear friends. Now I am going to speak on tips for topical SICS. As Professor TITIYAL has already said, there are different types of cataract surgery with excellent result. SICS is one of them. So SICS is also now proved. So proved to be equivalent to phaco surgery. Now, one of the disadvantages or one of the problem with SICS is to do topical surgery. So, as topical has become the topic of the day, people started demanding no injection cataract surgery. So, SICS surgeons should not think that they are not able to do topical surgery. So, I am going to speak few tips about the topical SICS. So, this is particularly for those SICS surgeons who are very comfortably doing surgeries and thinking of converting to SICS topical, but not able to do. So, when to start? In case of block failure, if you remain calm and complete the surgery, then you have perhaps reached the right stage to move on to topical surgery or topical SICS. So, you should not shout at the patient, your attendant, the person who has given the block. So slides not moving. Hello. Slides not moving. So while doing SIC, you have to think of avoiding certain things. Superior rectus suture is one of them because in topical, you have to make the patient very comfortable. So start avoiding superior rectus suture, avoid doing cautery, avoid dialing the IOL, and you have to reduce your surgical time because if the patient will feel uncomfortable, he will not cooperate with you. And you have to avoid your mental block. That topical cannot be done. This video. माउस नहीं है इधर. हाँ हाँ आगे. So many times people cooperate as if they have been blocked. So you can start doing without any superior rectus suture. Then you will have a little bit of bleeding because you are not doing any cautery. That also helps in healing of the sclerocorneal wound. Phaco sandwich technique I used to do SICs. Then IOL also can be put without dialing inside. And you can safely complete the surgery. So initially you have to avoid uncooperative patients, very old, hard of hearing, who will not be able to obey your comments. Immature cataracts because they take a little longer time. Deep set eyes also, small rigid pupil. Phenocane also helps in these cases. So these are the cases you have to avoid initially. Then otherwise topical SICs is possible and it is also a better option for the patients and for the surgeons also. Thank you very much. Thank you for present here.
Thank you for a nice presentation, Dr. Sarabsanshi. I request panelists, any comments on this? Dr. Rajshekhar.
Yeah, topical and block, the main difference is the comfort of the surgeon. The surgeon has to be extremely good in his skills because now another parameter of patient's pain sensitivity, the duration for which he can cooperate without anesthesia, and then again the eye moving and associated intraocular pressure situations during the surgery will come up. So if the surgeon is very comfortable, then they should move on to topical. So that's one very important factor. And during the surgery, if there are situations where things are going out of hand, one's ego shouldn't come in the way of giving a retrobulbar anesthesia or on the table, whatever anesthesia that's required to do it. Compared to phacoemulsification, SICS topical is little more challenging, but in skilled hands, it's still possible. And Dr. TITIYAL, please.
Thank you, thank you. Dr. Amaya?
Yeah, sir, are you giving any subtenance block?
No, only intracameral.
Yeah, I think as Dr. Rajshekhar pointed out, it is the comfort of a surgeon also,
Yes, yes.
and the patient's acceptance of a little bit of a strain which may be there. I would not mind giving a little bit of a subconjunctival in a incision area, because that is just area of concern, and then you can do a entire surgery with intracameral also. And SICS is the main surgery for India, almost 60-70% of surgeries SICS in the country, and people have to learn this surgical technique so that we can give a large number of surgeries, which is the mandate of a country now, to the every corner of this thing. You want to say something?
I think the main goal should be a good visual outcome
Yes.
first. So whether or not block is a different issue. And yes, definitely to move ahead with topical is a good step. But safety first, and definitely the goal should be that the visual outcome should not be compromised at any point. If you feel that the patient's cooperation or the patient has started wincing and not cooperating, then without compromising on that, we can only go ahead.
Now the patients have started demanding also no injection surgery. So in that case, the comfort level and the competence of the surgeon actually is the most important factor.
Yeah, so a good microscope with good visibility and good red glow will help
Everything has to
faster
be-
surgery. Definitely.
Thank you.
Thank you.
Wonderful
Very
skill,
nice
sir.
talk.
Thank you.
Thank you.
Thank you very much. Now we go to the next presentation, that is on our phaco and white cataracts. We'd like to invite Professor Dr. Sucheta Parija. She is head of department in AIMS Bhubaneswar. Where is she? So she's going to take us through the difficult scenario of cataract surgery, that too in a white cataracts. I hope that in Odisha we have more of white cataracts, either SICS or a phaco.
So good afternoon to you all, and respected chairperson and dignitaries. I'll be talking on phacoemulsification and white cataract. I have no financial interest in this presentation. So in the OPD, when we are sitting and seeing all types of cataracts, and we cannot name not all white cataracts are the same. If you look into the cataract, you see the first cataract which I am showing you. It's not painted with trypan blue. It's a cataract which is having a bluish hue. You go into detail and see the next cataract, you'll see the anterior capsule is fibrosed in these cases. You'll get cases with a white cataract where the cornea scar is there, and you know it is a traumatic cataract. Go in and you'll be seeing next cataracts, you'll see a yellowish hue, or the cortex is liquefied in these cases and more into the Morgagnan cataract. So spectrum of white cataract are there, and Bragitikos et al. Have classified it as type 1, type 2 and type 3. So main challenge we have when we are actually dealing with the intumescent white cataract with cortex liquefaction. Anterior segment OCT also helps you to look for the subcapsular clefts in the white cataract as described by Danny et al. But if you are good enough and have a eye OCT with you, which will be guiding you to see exactly the interlenticular clefts, and you will be actually helping you out to do your capsulorhexis as described by TITIYAL et al. So what are the surgical challenges? I'll be talking about the two main things, that is how we are going to handle the capsulorhexis and the nucleus management. So main is the difficulty in creating an intact adequate size capsule, and we see that 3.8% to 28.3%, we don't have a complete rhexis in those cases, and nucleus hardness also to assess it is difficult because we don't have a red glow. There is a weak and flaccid posterior capsule and absence of the epinucleus. So your technique which to be used and what complications can occur should be already made. So what are the challenges you have? So once you are seeing this type of intumescent cataract where the anterior capsule is bulged, there is a convexity, and once you go in and just give a nick, you'll see the milky fluid which is coming out, and then there is a chance of extension, and you can have the most dreaded complication, that is the runaway rhexis or a Argentine flag sign. So let's look at this case. This is a 52-year-old man who came to us. It's a white cataract. We are staining it, and I was lucky enough because the anterior capsule was fragile and we didn't have those milky fluid which was coming out. So we usually use the capsulorhexis, went ahead, and after doing a we had having done a capsulorhexis, what exactly the cataract was not very hard, so we went ahead and did a multi-quadrant chopping in these cases, and slowly we could take out each of this capsule, and finally, so let me complete. So be slow, that is what is enough is you keep enough of your trypan blue, be slow, assess each step, give high viscoelastics, and you can.
Here it's coming out well, sir.
Yeah.
Here it's getting burnt out. Change the settings.
Okay.
Okay.
Beautiful surgery.
Okay, 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 sir.
ये देखो ना क्या
I'll go there. I'll go there, sir.
यहाँ वीडियो अलग आ रहा है, मतलब ज़्यादा ब्राइट आ रहा है, ब्राइटनेस यहाँ ज़्यादा है, वहाँ अच्छा है। एक बार यहाँ देख लेना, आपको लैपटॉप पे कैसे।
इसका देना कंट्रोल
change the parameters of this,
Yeah,
so other
first
person may not choose.
इसको फुल स्क्रीन में कैसे आ रहा है, इधर तो ठीक आ रहा है, उधर क्या ब्राइट आ रहा है, उधर क्या। सर बोल रहे हैं, देखो
जैसे लैपटॉप पे दिख रहा है ना, उसी टाइप के यहाँ ना, लाइट ऑफ कर देना।
कौन सा लाइट ऑफ करता हमें नहीं चाहिए लाइट। कोई फर्क नहीं पड़ा, एटलीस्ट 5 डिग्री कम हो गया। It was like a Mumbai, now it's become proper.
हो गया।
हाँ हाँ ठीक है, उसके बाद संजय चौधरी को वहाँ ले आना। या कैरी ऑन प्लीज।
Yeah.
तो फर्क नहीं पड़ा। हाँ, you can go towards the end.
So, this repeating this same videos, I went on doing a capsulorhexis in these cases,
बहुत फॉरवर्ड कर लो।
and we did a phaco chop in this case, and slowly you have to be very meticulous, put in your high viscoelasticity and go about to do the chop. And finally, when you are taking out the last piece, be careful enough so that the PC doesn't come in into the play, and you will be good enough to take out all the cortical matter. Either you use a bimanual or a coaxial, and then do the PC polishing, and then you can put in a acrylic hydrophobic lens into the back. So there are other various techniques how to manage the capsulorhexis. You can do a 2-stage capsulorhexis which keep on teaching. So you do a smaller rhexis and then extend it to make it a bigger rhexis. You can use your phaco-prof, do the nick, aspirate all the cortical matter. You can keep on doing a frequent aspiration of the liquefied cortical matter. But what Dr. TITIYAL had described in one of his literature, you can use the femtolasers in these cases, and you can have a good capsulorhexis. So most important is the deciding factor to have a free floating capsulorhexis is to see that you don't have the gush of the milky fluid which is coming out, and you have to always assess the microadhesions which is there, and you take your capsulorhexis forceps and complete your rhexis in these cases. So after doing that, I'm going to show you. You are good enough, you have finished your case and you have done an adequate capsulorhexis. But in this case, this is a 52-year-old man who is having a diabetic. So this case was the density of the cataract was quite dense. So be minimal hydrodissection you have to do, don't rotate much. Be careful because you don't know how much is the posterior pressure in these cases, and in these cases what is happening because of that leathery type of cataract, I was not getting the full trench in each of the cases. But be meticulous, be slow, you can chop it how much is possible, take part and part of it, and you will be good enough to complete it with a slow process and use viscoelastics in these cases. And the best thing is you will be not having a clear cornea the next day, you can also see in this type of hard cataract on white cataracts. So incidence of capsular excess related complication is a posterior capsular rent, vitreous loss, or a nucleus drop. And density of the nucleus in with a hard cataract, there is a risk for the corneal endothelial trauma. And if your white cataract is associated with a small pupil, then you have to use the hooks in those cases and pupil expanders. If a PXF, you should always keep handy with the CTR and all. If it's a traumatic white cataract, well, you have to assess the situation and go ahead. So most important thing is, while performing the rexes, use sufficient high molecular weight viscoelastics, be gentle with your hydrodissection, mobilize the nucleus when you are giving hydrodissection so that you can release this posterior pressure, and then phaco-chop is ideal. So my take-home message is, always be pre-operatively make sure that is there a fluid from the decompensated lens proteins within the bag? That is, are you seeing the interlenticular or the convexity of the anterior capsule, which is a intumescent cataract where you will have a runaway rexus? Is the nucleus dense or relatively soft? Are there any other associated abnormalities? So this meticulous preoperative evaluation, good surgical planning will give you a success in most of the cases. Thank you.
Thank you, ma'am, for a wonderful presentation and good surgical videos. How do you deal with intumescent cataracts wherein you can't every time do CCC consistently?
So in most of the cases, you start with a smaller rexus, that is what usually 2 to 3 millimeter, 3 millimeter, you just don't plan to have a full 5 millimeter. So most important when you are making the nick, that is the thing, make a smaller nick, always use your capsular rexus forces, make it smaller, and after that you have done it, and then you again extend it and make it a bigger. If it is like 3-4 millimeter, you are good enough to soft cataract, you do it. You can put the intraocular lens in the bag and then again do an adequate rexus. Important thing that the IOL is covering all the edges, that is the capsular rexus is there.
Sir, what is your opinion about things that people do like punctorexis or doing, because you had a paper with femtosecond assisted rexis?
I think Dr. Rajendra Prasad will cover that also in difficult cases. We all understand, you have to differentiate, different types of white cataract. And you rightly pointed out what Dr. Kulkarni was saying. It is the intumescent white cataract where you'll have more chances of rexus getting uncontrolled and maybe towards the periphery also. There, with the examination, you can realize which type of intumescent we have. Sometimes you can aspirate with the needle. People go directly with the 26 gauge needle and aspirate. And some people do a small rexus, as Dr. Sucheta was telling, then aspirate, then complete your rexus. Some people do a punctorexis, which is also direct puncture to the, which may be little uncontrolled, except for Dr. Mohan Rajan, who can do very well. Then Dr. Rajendra Prasad, who has described a very nice swing needle punctures, multiple small puncture, which is a circular puncture, so the run gets extended as it is. So those various things are there which can be done. Most important words he talked about is a good examination of patient. If you realize what type of a white cataract you have, then accordingly you can do it. But if you have a anti-segment OCT, that gives a good picturization of morphology, then you can create different.
So basically it is the intralenticular pressure which is very high. So you need to increase the pressure in the anterior chamber to flatten the anterior capsule
These
so
high
that
viscoelastics.
the extension to the periphery, the risk is reduced. And if you make a smaller rexus, initially you can use a micro scissors and then use a micro forceps to enlarge the rexus also. And another thing is, usually if there is a fluid, that has a less propensity to go to the periphery rather than the swollen cortical fibers. There the propensity to go outside is more.
Thank you, Dr. Sucheta. Now we invite our friend Dr. Rajendra Prasad. You all know he's internationally renowned phacosurgeon, and he is currently the president of Delhi Ophthalmological Society, and has a terrific scientific mind, and he wants to create the scientific scenario in DOS itself by various scientific organizations. And he's described many techniques. He's known as an innovator In fact, his technique of terminal chop is very, very well known, and today he's going to show us difficult cases. Dr. Rajendra Prasad, please.
Thank you, Dr. TITIYAL, for the nice introduction, and good evening, friends, ladies and gentlemen. I'm going to take you through some of the difficult cases which I had operated. And this is the first case, and you can see here, this is a case of intumescent white cataract, but the patient has a very severe nystagmus, and you can see the oscillatory eye movement, which is quite evident and was quite difficult. This patient had a cardiac problem as well, and there was no option of giving him the retrobulbar or the general anesthesia. So we had to do this patient under topical anesthesia only. So you can see here, I have stained the anterior capsule, and see the eye movement. You have to hold the eye, and I'm giving now the main incision. So you have to be very careful in such cases, because these eye movements can hamper your movements, and making a capsular axis is, because I was trying to do the saving needle in this case, but was not possible because of the eye movement. So I created a cut on the anterior capsule, but luckily it didn't extend. I'm trying to evacuate the fluid from but you see the capsule is always trying to go towards the periphery. And somehow I'm trying to hold the eyeball, and just with the help of the capsular axis forceps, so I'm creating a capsular axis without taking it too large, trying to keep within the equator. And you can see I'm trying to create a little smaller axis, but I was lucky to complete the axis. So you see the fluffy cortical material and the fluid which was there has come out. The nucleus wasn't very hard, it was a quite soft nucleus, but I'm trying to chop this nucleus now. This is how I divided the nucleus into two pieces, and emulsification of the such nucleus is not very difficult, because the nucleus is generally very on the softer side, and you can very simply take out these pieces, and with the help of the phaco probe and emulsify and complete the emulsification slowly. And this is the last piece. You have to be very careful, because there is eye movement, and at the same time the manipulation becomes very difficult, so you must be careful. I'm trying to remove the cortical material out of the capsular bag, and this is how you complete the cortical removal. And then placement of the IOL is not going to be very difficult, because once you take the cartridge inside, so you can hold the eyeball, and this is how I completed the IOL placement to the back. So in these cases, the presence of the preoperative nystagmus results into worse visual outcome generally, and the resolution of the preoperative nystagmus after the cataract surgery has been documented in several studies. Immobilize the eye with a second instrument while making the incisions, and surgical instruments in the eye dampens the nystagmus. So this is how you can complete the surgery in such cases, and this is what you have seen. This is the second case which I'm going to show you. This is a traumatic cataract. The patient had a trauma, a long back, and had come up. This is one-eyed patient. The other eye is completely damaged, and this eye, this is the seeing eye has this condition. So it was a quite challenging case. There wasn't any capsule. The anterior capsule was disrupted. The nuclear material was almost shrunk and hardened, and the rest of the cortical material was also almost in the periphery. And so I tried to stain the anterior capsule. So this is how you stain. I'm just trying to see whether the capsule is there or no, some part of the capsule. And went inside, started from little periphery, because the center there was nothing. So this is how I just removed the whatever anterior capsule was there in the part of this cataract. Once the capsule was removed, I went with the irrigation and aspiration cannula because there wasn't any nucleus as such, and trying to remove whatever cortical material was possible to remove. And you can see because the lens material was almost fibrous and calcified, so I used the hook just to detach that material out of the capsule. But at the same, there is a posterior capsule disruption also because the central part, which is fibrosed. So that helped us that not having the extension of the tear further because there is a fibrosis also. So then went inside with the phaco probe and trying to emulsify these fibrous material and the part of the nucleus material, whatever was there inside. This is how I'm trying to remove these pieces. I'm trying to hook them and to bring on the phaco probe because you can't go into the material with the phaco probe because these materials are attached to the posterior capsule. And slowly and slowly I'm trying to bring these pieces with the help of the hook only, second instrument, and bringing on the phaco probe. And this is how I could remove most of the material from one section of the capsular bag. And then went inside with the help of the Rexis forceps and trying to remove these membranes. So you can see here the membrane, a lot of membranous material was there, and tried to remove this material with the help of the forceps. But on this section, you can see the material is still lying. Now this is somewhat like the fibrosed L-Shinning's pearls, and which is actually the cortical material which has changed into the little solidification, and so this is a complete one part of that pearl which I brought out from that area of the capsular bag and trying to remove it, but it was not possible. I had to go inside with the phaco probe again, and then emulsified and phaco aspirated that material. Very slowly, you have to very slowly because there is a tear also, posterior tear, but and the remaining membrane, I'm just again went inside with the with the Rexis forceps and trying to remove that membrane. So you can see I could remove most of the membranous part from the capsular bag. And you can see, the capsular bag is fairly clear now. So very little fibrotic material is left at some part of that capsule. The anterior capsule is not there, it's completely disrupted. Posterior capsule has the fibrosis at one section, and then I'm trying to put the IOL inside. Now this is the hydrophobic IOL which is going inside, and I'm trying to put it in within the capsule only because the part of the two capsules become on the side. So both the haptic went inside the capsular bag only. So this is how the surgery completed, and you can see in these traumatic cataract, generally with the sharp penetrating injury, what happens because you have an anterior and posterior capsular injury in this particular case. There could be a subluxation and dislocation of the lens material also. Many times there could be intraocular foreign body and vitreoretinal injury also. And because since this injury was quite long back because the patient couldn't dare for the surgery, so there could be amblyopic changes also in this particular case. So what we need to do is we need to take very carefully operate these cases. And as I have done the anterior capsular stain, always do that so that you could see whatever remnant of the anterior capsule is left, you could remove that. Anterior capsular tear should be converted into capsular rexis, and retain the posterior capsule as much as possible, and do not disturb the posterior capsule, and try to put the IOL within the capsular bag. So I'll just finish my talk here, and thank you very much.
Thank you, Dr. Rajendra Prasad. It was wonderful seeing both the videos, very masterly managed the two difficult cases. Just one query in a nystagmus patient. What would be, our preferred intraocular lens in those cases?
In the second case?
No, first case. With the nystagmus, which type of lens we should implant in those cases?
See, actually, because once you have a nystagmus, these cases with the nystagmus could have a visual depreciation also. So it's always to go in for the simple monofocal IOL only. Never go for the multifocal or trifocal IOLs. So monofocal IOL, that too hydrophobic monofocal IOL would be the best for these cases.
I think that's a very, very important point, because the eye will be jerking and there won't be a good null point in these cases, and multifocal, rightly pointed out, may not be a good idea. But if you could put a good monofocal lens, even if you have a large, sometimes these patient can have a corneal toricity also. The toric IOL may be implanted, but monofocal, you rightly pointed out, so beautifully done surgery. It would have been a very difficult, especially doing that capsular access was terrific.
Yeah.
Any comments?
Thank you, sir.
No, that was excellent demonstration of surgical skills. So, hats off, well done.
Thank you very much.
Any comments?
In traumatic cataract, you should be prepared for plan B also, because while doing all that, there could be posterior capsular rupture or even a drop of the nuclear fragments. So, depending on was it a child, that traumatic cataract?
No, this was an adult patient who had an injury in childhood.
Yeah. So, yeah, you should have a backup pars plana plan also in this case, but very well managed.
Yeah, that is very important, because this patient, the injury, penetrating injury went through the posterior capsule also, but somehow there is a fibrosis, so during the surgery it didn't disrupt. And the important point what you have seen in my case is, because I use very less phacoprobe, and I was trying to handle most of the surgical part with the irrigation and aspiration controller, so you have a much better control on the capsule and the lens material. So that is very important, because you have to be very careful, like if it disrupts, then you may have the problem.
Thank you, Dr.
Thank you, sir. Thank you very much.
Mr. Dr. Sanjay. Yeah.
Thank you so much, sir, for the wonderful presentation. I'd like to invite Dr. Sanjay Chaudhary for the next talk on IOL explantation, safe wait period. He's a brilliant surgeon and an amazing speaker with loads of experience, and he will now enlighten us with his talk.
Thank you, Naga. This mic is not working properly. Okay.
Mic on kar do boss ka. We are putting lenses, you are explanting lenses. Kya baat hai?
Okay, yeah, that's fine. Thank you. Okay, so many times you have to explant a lens. And the question is, how do you explant it safely? And what is the right time to explant an IOL or exchange an IOL? So I had different conditions. Of course, we know it from theory when to do it, but I could show you practically in some situations of how to go about it. So here's a patient who came for a second follow-up at 15 days, and we realized that he has a toric lens, you can see that, and we realized that instead of the toricity getting reduced, it doubled up. That means it was 2-cylinder, it became 4-cylinder. That means the lens was placed at an axis 90 degree to its actual required position. So it was 2 weeks. The lens does not get trapped or encapsulated, or there's a shrink wrap effect. So you can just open up the bag, put viscoelastic, and do what is called the visco dissection. The visco wave passes under the IOL, you do a counter pressure, the lens is free, you can rotate it in position, and the job is done. So, it is best that when the patient comes at 2 weeks, and you see that this lens has to be rotated, dialed, explanted, or anything, that's the best time. Now, we'll show you another situation, what happens at 3 weeks. So here was this patient, and the IOL had to be taken out for some reason, and we again tried to first separate the anterior capsule and then do a visco dissection. You can see that little fiber going under the IOL. So that's an idea of how the visco is moving under the IOL. Counter pressure. The visco wave is complete, and then we try to pull out the lens from the capsular bag and see what happens. The optics are clear, but the haptics are entangled in the fornix of the bag in a fibrotic hold. Now see the other side also. A routine IQ lens, a very friendly lens in the eye. And see this hold on the haptics in the capsular bag by some fibrotic bands which are holding the haptics in the bag. So, inference at 3 weeks, the fibrosis kind of sets in. It becomes a little difficult to take out the lens out of the bag at 3 weeks, but 3 weeks, 4 weeks, it is doable with a little effort. Then let's have another situation. An opacified lens 4 years after surgery came for a lens exchange 4 years after surgery. You would have had all that shrink wrap effect, fibrosis, adherent of the capsule to the lens, strongly adherent haptics to the fornix of the bag. How do you handle it? So my first job was to find one point of entry where I could enter my probe under the anterior capsule, between the anterior capsule and the IOL. I'm just searching for that one point where I can enter in, because the whole thing is stuck to the IOL. I got one point of entry, and then I can move it around and separate the anterior capsule from the optics of the IOL. So this is separation of 1/2. Now I'm trying for the other side. Again, I'm not gaining an entry here. So I go through the previous part of the entry and separate the anterior capsule. Now the anterior capsule is separated. Now the big challenge. See the kind of hold of the optics in the capsular fornix, highly fibrosed. I'm trying counter pressure to pull this out, because it would have pulled the bag, the zonules, and there would have been a bag dehiscence and everything, but still with counter pressure trying to keep the capsule in position, I am able to bring out the haptic from out of the bag. See, I'm again giving counter pressure to the fornix in the bag, so that I don't want the whole bag to come out with the haptics. Any times you can almost see the edge of the capsular bag and the zonules, but somehow I managed to get it out. Now, the carry home point here is, what if the adhesion was so tight that I could not separate it from the capsular bag? What would I have done? So what I would have done is, I would have chopped off the haptics. Let the haptics be there, bring out the IOL only, and then put another IOL in the bag. So the take-home messages here would be, at 2 weeks, when the patient is coming for a follow-up, if there is a problem, do it then. You have 2 weeks, 3 weeks to take your decision. 3 weeks, the fibrosis starts setting in. And 3 months onwards, you can never be sure how much of fibrosis has set in. Then it is your stake, it is your chance. You could be successful, you could get caught up in a difficult situation, but even difficult situations are manageable. Thank you so much.
What I'm saying is that this is good to show that at early post-op, of course, it is easier to take it out. I think it would also depend on how the original surgery has gone. like the last case didn't look, you know, a very simple case, or didn't look as though everything would have gone well, because the rexus was not circular. So it will also depend on the architecture of your rexus at the primary surgery and how the surgery has, you know, gone. Even if the case is old, but if your capsulorhexis is circular and it's actually overlapping the edges of the optic, then it's easy to do it, rather than, you know, if it is extending to one side, and then things can get difficult.
True.
Just one more point, sir. Once you detect any kind of fibrosis, as you said, after 3 weeks, would it be prudent to just cut at the optic-haptic junction and leave the haptics be and take out the optic and put another IOL?
See, you could do it, but if you know your timing well, and you know at this time I can do it, and when you pull out the haptics, you don't just pull it out. You have to pull a very slow and a steady pull. Keep watching for the edge of the capsule. If it is pulling the edge of the capsule and the zonules, then you try to give a counter pressure with an instrument, but not that strong enough because the counter pressure punctures the capsule and goes out. So it's all a balance. And if it is not working, then you chop it off. Thank you.
Taking out the entire lens through the bag definitely, you know, some journalists would have, you know, been stressed.
So we put a CTR.
You have a, you know, option. We should put a CTR in those cases also. Then do our procedures.
True. I had another video, but time was 7 minutes, so I had to cut that.
Thank you for making up the time. Thank you.
Thank you.
Thank you, sir. I'd like to now invite Dr. Namrata Sharma, madam, with her expertise, and she is our dynamic secretary AOS, and she would enlighten us with toric IOL implantation in difficult situations.
Thank you, Naga. I would be talking to you about toric IOLs in difficult situations. And aim for toric intraocular lenses and the problems whenever you implant them, especially in difficult situations, could be sometimes assessment of corneal astigmatism, like when you have a corneal opacity, a precise calculation of IOL power, accurate marking is important, proper alignment is important, and achievement of an accurate and stable post-op IOL alignment is required. This is not coming on the screen. AV team? AV team is not attentive at all. So the difficult situation could be subluxated cataract, small pupil, corneal opacity, in extreme of ectasia, and after you have calculated the intraocular lens power and also this kind of a sheet which is available with most manufacturers is given. This is just to highlight a case in which how you have to fine-tune the position when you're doing a toric intraocular lens implantation. And this is a Callisto guided system. Even if you don't have it, you can manually mark it. An important thing is that just before you do irrigation aspiration, your mark should be about 2 degrees away from your intended axis. And then after doing the hydration, one can slowly nudge the lens into the position so that it completely aligns with the marks which are present on the Callisto. Now, sometimes you can have a torn capsulorhexis in the proximal part. In this case, again, the toric intraocular lens was planned, but notice that on the proximal part, there is a torn capsulorhexis that is present, and it's like a keyhole rhexis there. Again, because the axis of the keyhole rhexis, which is torn, as well as the axis at which you have to actually align the lens is nearly the same, although it is slightly different, but not exactly same. So it is important that you don't manipulate at that area really too much. So even if it goes off center a little bit, rather than rotating the entire lens to its 360 degrees and coming back here, it is important that you just nudge it a little bit so that you get the correct axis without having to open that keyhole rhexis completely and extending the tear posteriorly. Then in small pupil also, it's always a challenge to do a capsulorhexis and to do a toric intraocular lens implantation. Again, one must do rhexis as much as the pupil allows you, and it should be a circular rhexis. Nuclear emulsification, irrigation, aspiration, of course, is being done in this case, and the challenge would be an intraocular lens implantation. But as you implant the lens, you can also see at what axis it is going. And then at least from one edge, one can always use a Sinskey hook to see at what level these markings are. Here you can see as the irrigation aspiration is being used, the pupil slightly dilates, and then you know that it is the correct axis. Now, again, at times, in cases of small pupil toric intraocular lens implantation, this is a hard cataract. So if it's a hard cataract, it may not be very easy to do a small pupil phaco and then implant the intraocular lens, which is toric. So it is best to put the nylon hooks there and then subsequently do an intraocular lens implantation. And in such cases, again, one can place the marks along the axis, which is being shown by the callisto here again. And then this is followed by the hydration. Now, in cases of subluxated cataracts also, sometimes it can be difficult to put a toric intraocular lens. In this case, subluxation was in fact detected on the table itself, and it was a subtle, small subluxation. So an CTR is being implanted, followed by irrigation and aspiration. Of course, this can become a little tricky because the cortical fibers, they get trapped in the CTR ring. And then this is again followed by the placement of the lens. Again, important thing is that sometimes because from the area of the subluxation, the air bubble can go at the back. Important thing is that you align the lens in the correct direction. And as you hydrate the wound and as you end the surgery, this bubble should be out. Now, in cases of pellucid marginal degeneration or ectasia such as this, which is more in the periphery and sparing almost the central part, one can use customized toric lenses as was used in this case. And after doing this surgery, this is the customized toric intraocular lens implantation which is being done. And these cases do well, especially the pellucid marginal degeneration, because the center part doesn't get affected as much as the periphery does. So again, in such cases, if you are planning not to do a corneal transplantation procedure and the astigmatism does have some amount of, as seen on the corneal topography map, some amount of astigmatism is there which is regular. Always these cases will have some amount of irregular astigmatism as well. But if there's substantial amount of astigmatism which is regular, then one can do a toric intraocular lens implantation also in these cases after doing phacoemulsification, irrigation, aspiration. And the intraocular lenses, toric intraocular lenses can be implanted in these cases in the axis, which is again as shown by the callisto. Now, again, post-DALCs, it can be a little tricky, and again, the prerequisite is the same, that there should be some amount of regular astigmatism that is present. We've recently analyzed our cases post-DALC cataracts, and we found that as compared to the conventional cases, these do tend to have a lot more rotation, and this is possibly related to the fact that these DALCs have been done most often in the keratoconic cases, and also to the fact that they do have deep anterior chambers. Now, this is just to show the toric post-op CPs of some of the cases which were, some of them which were small pupils, some of them which were bang on, and this should be the eye trace endpoint. And this was a toric IOL in a poorly dilating pupil with a post-op eye trace. This was in a subluxated lens with the aberrations which have come down markedly in the post-op period. So to conclude, toric IOL implantation is possible in selected difficult situations like extended rexes, small pupil with aids like nylon hooks, mild subluxation with aids like CTR, and ectasias and even post-keratoplasty, but the central 3 mm should have a fairly regular astigmatism. And of course, patient counseling is the key, because sometimes you may not be able to actually put in a toric intraocular lens, especially if there is a problem, especially if you have a large posterior capsular tear, then it may not be possible to put it. So thank you very much for your kind attention. So for the keratoconus patient, we actually rely more on the Keynes formula. Of course, in this case, again, the Barrett True K was used, but given a choice, Keynes formula would be a better option to calculate the IOL power as. Sorry? So post-operative, like I said, that in those cases, especially cases with a corneal opacity, of course, it did neutralize some amount of the regular astigmatism that was present. But irregular astigmatism is something that we cannot address by this.
Okay. Thank you, Namrata. Okay, we invite Dr. Rajesh Sinha, who's going to talk about managing cataract in eyes with corneal opacity and haze. I think this also requires a huge attention from surgeons. Dr. Rajesh, please.
Thank you, sir. Very good afternoon to all of you. When you have a cataract with a corneal opacity, the ideal treatment is to do a corneal triple procedure. However, there are situations wherein you can have an opacity with vascularization, where there's a risk of graft rejection, the patient is one-eyed, cannot come for follow-up. In all these scenarios, if you can do a cataract surgery and if the opacity is not completely covering the cornea, then in that case, if you can do a cataract surgery and provide a reasonably good visual outcome for the life, for the whole life of the patient, that may be preferable. So the idea of presenting this, doing this presentation is to discuss methods to enhance visualization, because whenever there is a corneal opacity or a haze, the visibility behind that to do a cataract surgery is difficult. So in order to improve visualization, the first and foremost thing is that we should have a well-dilated pupil, and if it's not there, then in that case you can inject some drugs like adrenaline, you can put hooks, etc. And many times if you have to do some manipulation in the iris, in that case it's preferable to do under peribulbar or subtenon block. Trap and blue, since the time it came, has been very useful in white cataracts, and when there is an opacity, it's preferable to use trap and blue for a slightly longer period so as to stain the capsule dark, so that you can do a capsular excess, and later on, while doing chopping of the nucleus, at that time also you can see the capsular margin and you don't accidentally chop the margin of the capsular excess. So that's the reason why one should use trap and blue for a longer period. Now, if you have an opacity like this and you are doing a capsular excess, then in that case, once you start the capsular excess, you have held it, you don't stop behind the opacity. You stop where opposite the cornea, which is clear, so that you can hold the capsular excess margin once again and complete it. Now, another important thing is that you can use all sorts of viscoelastic inside the anterior chamber, which can coat the endothelium. You should also use viscodispersive viscoelastic on the surface of the cornea, so that it increases the visualization at that particular time. And whenever you are doing some manipulation, you are doing a, say, chopping technique, put a blob of viscoelastic on the cornea, and that clears up the visibility, improves significantly. As I said, good quality viscoelastic is essential not only over the surface but inside the eye. That's something that can coat the endothelium. Sometimes you have a opacity which is small, and if the cataract is not very hard, then you can manage without putting any enlarging the pupil. But here it's a black cataract wherein it is very difficult. So in such a case, it's better to put iris hooks to improve visualization. Another technique was, if you have a central opacity, you can do slightly eccentric, not exactly in the periphery, but slightly eccentric crater, and that helps you in chopping. Endo illuminator is again a good tool which can improve visualization while doing a procedure in a hazy cornea. The endo illuminator can be held by your assistant. It can be used from outside. The assistant can show it from outside while you are chopping the nucleus. And once you have chopped it and you have to remove the epinuclear plate, then you can take the endo illuminator inside, so that you can very easily delineate the capsule and the endonuclear margin, and thereby you can remove the endonucleus completely without causing any damage to the capsule. This is how you can see how well the endo illuminator is helping. You can use chandelier illumination from the pars plana, and this, in a case of a hazy cornea, slightly hazy cornea, it improves the glow, and once you get a red glow, you can do a rhexis and complete the procedure. as far as the IOL is concerned, if you have an opacity in the center, one should never think of putting anything except monofocal spherical IOL. But if you have an opacity in the periphery causing some astigmatism, then in that case you can put a toric implant, and particularly in this particular case wherein there is some degree of zonal adhesions as well, you can put an endocapsular ring and then put a toric implant. Long back we did a study under Professor TITIYAL sir. It was published in 2002 if I remember correctly. This was a series of cases wherein we had corneal opacity and cataract. And what we did is we did the cataract surgery and did small sphincterotomies at the margins so that we could create a pupil adjacent to the opacity. So this part is being covered by the opacity, but once you have put the IOL, a small pupil is created because of the sphincterotomy. If you do a large optical iridectomy, then in that case you can have an aphakic and a pseudophakic zone, and that can have confusion and diplopia. But if you do a small sphincterotomy, it is really helpful, and that was published. If you have an opacity which is covering the cornea significantly, in such a case you can do an anterior lamellar keratoplasty. Once you cut it, you can see how clear it is, and once the cornea clears up, by removing the superficial hazy cornea, you can go ahead and complete the cataract procedure, and once the cataract procedure is complete, you can place the intraocular lens, and then after that you can put a donor lenticule, and then you can suture it. If the opacity is extending only up to about 150 microns or 200 microns, you can do a sutureless anterior lamellar keratoplasty, but if the opacity is deeper, you have to put a suture. Another scenario wherein it's a vascularized opacity which is extending quite significantly, you can see intraoperative opacity is showing about 80% of the cornea is having the opacity. So in such a case you can do a lamellar graft and leave little bit of stroma, and after dissection of the superficial hazy cornea, you can leave little bit of stroma and then go ahead and complete the cataract surgery. Once you have dissected it, you can put a viscoelastic on the surface, and that improves the visualization. Particularly in a one-eyed individual wherein the other eye is thusical, as was in this case, doing a lamellar external extraocular procedure, which is an anterior lamellar keratoplasty, is better than a full thickness graft. So in conclusion, in a case of an opacity like this, where there is a cataract as well, in such a case, particularly if the cornea is vascularized, the risk of rejection is high, a patient cannot come for follow-up, he's one-eyed, you can do a cataract surgery. You enhance visualization by use of trap-in blue dye, by use of OVD on the surface, by use of endo-illuminator or chandelier illumination. And if you have a clear cornea in this area, you can do a small sphincterotomy in this area so as to provide a good, reasonably good visual outcome for the whole of the patient's life. So thank you very much for your patient listening.
Thank you, Rajesh. And you missed the second last slide. Thank you for a nice presentation. I'd like to give a thumbs up to the scientific committee chairpersons and the members for managing this midterm conference so nicely. And I'd like to thank all the speakers and the chairpersons. I think we can take one question from the audience, because we covered right from SICS to a difficult situation of cataract surgery. Actually, another set of people have come. Huh? Yeah, next session is thank you again, and wish you all the best. अभी आ रहे हैं 2-3 लोग राजेश इधर राजेश साइड बैलेंस करते हैं इधर बैलेंस नहीं हो रहा अभी आप ऊपर से लाइटिंग यहाँ खोपड़ी है इसका तो कुछ फायदा नहीं है ना बोले राइट मोबाइल मेरा